Hey, everybody. Welcome to our first NCSA webinar of 2022. My name is Jill Escher. I am president of NCSA, and I'm very pleased to be presenting this webinar today on the crisis in crisis care. This is a topic that we hear from, I would say, virtually every day from members of our community who are experiencing crisis at home or in the ER or in a hospital. Sometimes related to care homes as well. And it's an area of tremendous need. I will not be moderating today. I am turning over moderation to one of our committee members, and her name is Jackie Cansier. She is based in Tennessee. She is the mother of Jaden, a daughter who has severe autism and who is also diagnosed with a rare genetic syndrome called SYNGAP1. She has been a disability education advocate and really an amazing one since 1995. And in more recent years, she has been a very strong advocate for home and community-based services and Medicaid funded services and for improved crisis care, because she has lived it herself. Jackie, I'm going to ask you to come on, and Jackie will be introducing our three wonderful speakers today. And we'll also talk to you about how to use, Q&A and how questions will be handled. Okay. All right. Thank you so much, Jackie.
Thank you, Jill. I appreciate it. Thank you, everyone that has tuned in with us today. I know that a lot of you have asked for this very topic, which is the crisis in crisis care. And so NCSA has put together what I believe is really going to be a useful panel today. There will be Q&A following at the very end. And so you'll want to stay tuned. You can use your chat box to ask questions or to just talk with one another there, as well as there's a Q&A box down below. And you can put specific questions you would like asked in that, that Q&A box, and we will ask those at the end. Today, we are going to have Karen and Michelle speak first, and then that will be followed by Amanda. Michelle Bagby is the Tennessee Director of Behavioral Health and Crisis Services. And she also has started, she's the Clinical Director for Tennessee START AST, which is really a great program that we personally know about here in our home, and that's why I asked Michelle to come on to share about that. And Karen Weigel is the Associate Director actually for the National START program that comes out of the University of New Hampshire. And so together, the two of them will be helping to explain some of what START is and how that can help with the crisis services. Amanda Lapreme is a VCBAD out of Rochester, New York, who is just kind of on fire. She's fantastic at collecting data and research and turning that into useful programs. And so she has some really exciting information for us. And whether you are a parent or a provider, or even a state politician that is looking at what kinds of crisis services are there and what should we be looking for, and what are those gaps, and what are the barriers to that, and how do we fund things if we do need them? I really feel like a lot of those questions are going to be answered in this presentation today. And so with that, I'll let the presenters be the ones to share all this information. And Michelle, Karen, are you guys ready?
Yes, we are.
Great. Then I will sign off, and the floor is all yours.
Thank you.
All right, well, thank you guys, and welcome. We're so happy that so many of you could join us today. As Jackie mentioned, Karen and I are going to be talking about START, the Center for START Services, but I'm also going to be sharing quite a bit of information about how we've implemented the START model here in Tennessee. So to give you a background on the START model, Dr. Weigley is going to start us off here, and I'm probably going to say START in an unintended way multiple times throughout this presentation, just like I did. But Dr. Weigley is going to start us off with an overview of what START is and where the model comes from, and kind of give us that background. And then I'll talk more about how we have put that in place here in the state of Tennessee. So Karen.
Thank you, Michelle, and thank you, Jackie and Jill, for inviting us here today to talk about this. So as was mentioned, I'm the Associate Director at the Center for START Services, and the National Center was started in 2009, I think with 3 of us, when we decided that we should make sure that we were associated with the USAID to help us establish more of our research background and evidence base for the model that Dr. Joan Beasley had been implementing since 1988. So if you would turn the page, Michelle. This at the National Center for START Services, we kind of have 3 arms. We have a portion of it actually teaches different entities like the state of Tennessee how to implement a START program. So we support that through one of our missions. Another mission is training and professional development. And if you do go to the website, the link at the end of this, you will see that we have specific training, not just available to START programs in our START network, but anybody anywhere can join some of our trainings around the mental health aspects of IDD. And by IDD, I mean intellectual and developmental disabilities, which includes autism. And the third arm is our research and evaluation portion, which also ties into all of these. As you can see, these all overlap, the nice little Venn diagram. So what is the START model? If you can head one forward, it is a fidelity-based model, which means we use research to tell us what is working and what is not working. We also strongly believe that what you receive should not depend on where you live. It's really important that people in all areas, geographic areas, have equal access to necessary and appropriate services. So we work to achieve both access, appropriateness of care, and accountability. So we really work to ensure that everybody who is part of our network is accountable to what they're doing, which is why we use research, right? And our overall goal is to build the capacity of existing systems to be able to provide appropriate supports to people with IDD and intensive behavioral health needs. So next slide, please. I'm going to talk to you about what is START really briefly, give you an overview of what the START model is. So START is a systemic therapeutic assessment, resources, and treatment. So that is a mouthful. No wonder we call it START. And it is a crisis intervention and prevention model for people with intellectual and developmental disabilities. So we help to establish these programs to serve this population that tends to fall between the cracks of existing service systems in the United States right now. And I will say also in Canada and the UK and Australia and Korea, other people with whom we have been associated and worked, whose systems are also very divided between healthcare, mental health care, and care for people with IDD. So we work with the people who fall through the cracks where, for instance, the IDD system may say, oh, this person's behavior problems are too intense, we don't know what to do. So they're yours, maybe sending somebody to mental health services. And the mental health system says, no, if you have IDD, we don't know what to do with you, they're yours. And hospitals say, we don't know how to treat this person. So there are a lot of reasons that occurs. And our mission is to help build the capacity of all of these systems so that it is common knowledge how to integrate care for people with these intensive needs, as well as how to adapt what you're already doing. So for instance, I like to think about like diabetes. When do you remember when your parents or at school, they taught you what diabetes is? I'm going to guess everybody's saying no. You just know, right? So when we want to make knowledge about intellectual and developmental disabilities and acute care needs to be known. It's not a specialized service in particular, although I know some people still need specialized services, obviously right now a lot. Our main goal is to make it so that it's not foreign, it's not frightening. People aren't afraid that they can't do what is needed to support these people, so that IDD is not keep you from accessing services that you otherwise need, just like diabetes doesn't, right? So this is a diagram of what a START clinical team looks like. And this is super complicated. I'm going to briefly overview this for you. So the things in blue squares are what START does. What does START do? What are some of the services they do? Who is part of a START team? The orange squares include funding and administrative oversight for the START teams, such as stakeholders. Who brought this here in the first place, which Michelle is going to talk about in Tennessee. Who are the funders? How did this become part of a policy, or how can we get it to be part of a policy in your state? And we need those strong partners for START teams and START programs to be successful. And we're a part of that, the National Center for START Services. As I mentioned, we work very closely with teams that are in development and early implementation. And we do a lot of training and technical assistance. We have quality assurance measures to ensure fidelity to following the model. All of our teams enter data into our START information reporting system, our SIRS database. We now have data on over 13,000 people with IDD who have received services through different START programs. And we use that to tell us about what we're doing, what's working, what's not working. We also teach teams to use that individually to do so. The green here are the linkages and network partners. So every START program develops their own advisory committee of funders, people with lived experiences, families, stakeholders, policy planners, in order to provide feedback about how implementation in any unique location is going and what do we need to do to adapt that. We also link with current providers, as you can see here on the list. And we work to establish relationships with these different service entities so that we can impact how they care for people in our population. We can influence them, train them, and become partners in learning some new and more effective techniques. Okay, can you please? Okay, so around that primary intervention, just so you know, START is a public health model. We use the public health model to guide all of our activities in a START program. So back to the diabetes, right? Primary intervention has happened in a community level so that pretty much everybody knows what diabetes is these days. We want and kind of knows how it occurs, at least type 2. People know a little bit more about that than type 1. What are some things you can do to maybe ameliorate some of your risk factors? What do you do once you have that? So what we want is for care for this population to end up there, right? We need more and more people to be aware and knowledgeable about what to do and how to approach people and work with people with IDD and severe behavioral health needs. We also provide that secondary intervention, which is the training, the specialized work around individuals to figure out what is happening, how can we prevent crises, what do we do to help the rest of the care provider, the care system, the families know how to support that person in stability. We also provide immediate crisis response 24/7 in order to help face what's happening, right? We know that the options decrease when we get to that point. So when people are in an emergency room, we go with them. The START teams go with and help problem solve around what is actually needed. Because in a lot of cases, emergency department staff will tell you themselves that they don't know what to do. So there's often chemical or physical restraints used or other very temporary and not necessarily helpful interventions provided. So we go along, the START team members go along with the person and help problem solve and advocate for what might be the most useful, and continually problem solve, bring the person back to stability and the system. So it's not just about stabilizing the person, but stabilizing everybody who supports that person. And one thing I'm going to say really quick is at START, we define a crisis as a problem without the tools to address it. So that's why everybody goes into crisis. We don't know what to do, or the options that we have are not truly what we need. That doesn't exist right now. Okay, next slide. So a huge part of what we do is looking at all the biopsychosocial factors that might be impacting this person as well as the system, and how those help us predict the potential occurrence of crises, and what can we do ahead of time to address those so that the person doesn't go into crisis. Next slide, please. That the biopsychosocial view, it's not just lip service, it's part of everyday conceptualization of our work, as well as Perma. So Perma is a research-based acronym of what are the sort of ingredients that help lead to stability and wellness and health, not just a lack of crisis, but an improved life with that also leads to health and wellness, right? Not just halfway, like, okay, we're no longer in crisis, we're okay, we're stable. No, well, how do we flourish? How do we ensure that everybody we work with is having their best life? The ingredients are positive emotions, engagement, relationships, meaning, and achievement. So everything that we do to prevent a crisis, we also consider these pieces. How do we, while preventing a crisis, also embed these aspects of wellness, PERMA, into a person's life, so that it not only we find it helps avoid crisis in the first place, but it also helps people get out of crisis situations more quickly. So overall, our methods include assessment and coaching, ongoing linkages with all of the systemic partners who provide support and care to this person, collaboration on problem solving. People who go through our training who become START team members, they go through a certification process. It is equivalent to another master's degree. For most people, they are master's level. They oftentimes tell us that it was harder than their master's degree, but also more rewarding. So we know it's not easy. We also include therapeutic coaching, so that we're not just saying, here, parent or caregiver, here's a good thing to do. We actually work together to figure out how do we actually implement some strategies in this person's everyday life to make them useful and actually doable. And we provide cross systems crisis prevention and intervention planning. So we don't go home and develop a plan and come back and say, here, you guys do this. We work with the existing system of care to say what works when, and then we show up at a crisis and we find out, guess what? We were wrong. That really didn't work. So maybe let's try this next time. Or, oh, that part of it worked. So let's make sure we keep that in our planning. So it's an ongoing collaborative partnership. Next slide, please. I thought I would have mentioned just a very few outcomes associated with the START programs. So we use all of that data we have in our database and publish on outcomes associated with being enrolled in START services. So across the US, several improvements have been shown, including these three, which there's a bunch more. High rates of stabilization following long periods of crisis, Sometimes people who are referred to START have been in crisis for years, basically. And so the vast majority of people are stabilized typically in 8 to 9 months. A typical length of stay, meaning a time of service that somebody is enrolled in START, is about 14 months. We see a dramatic reduction in psychiatric hospitalizations and emergency department usage. And we find increased satisfaction with mental health and support services. So we don't just measure what we do, we measure our impact on the rest of the system and their capacity to provide support to the people we serve. Next slide. Thank you. So this is our website, the Center for Start Services.org. And if you do the / locations, you can see where there are existing START programs. Also, under the resources link on our page, you can see a lot more research and outcome data around the implementation of the START model. At our website, we have little movies, and I executive produced the START movie. I think it's great, but there are 3 segments that kind of demonstrate what I talked about, because it's not so easy to conceptualize. It sounds easy to conceptualize. When you see it in action, it's very helpful to explain it even better. So if
Hey,
you have
Karen,
questions,
this is
yeah,
Jill. I'm gonna
Yeah.
butt in with just a little request for some clarification.
sure.
You haven't yet really defined what crisis is in the context of severe autism. So can you give some examples of your
can.
clients with severe autism who have been in crisis as START defines it?
Yes. So again, our general definition is a problem without the tools to solve it. The people who get referred to us are people, I'm thinking of an example right now that Michelle is aware of and serving in her team. This person bit off their finger and has done major damage to their eye recently. People who have attempted suicide by running into traffic in the middle of we may call it a meltdown. People who haven't slept, parents who haven't slept in years because of trying to keep their child safe. And there are myriad examples, but yes, a lot of people who are referred to us, about over half, about 60% fully of the service enrollees for START do have autism, and typically a form of severe autism. So very common self-injury, serious elopement, or what we call leaving unexpectedly. People which seem to panic and run and dart into dangerous situations. People who sometimes become very aggressive and hurt others or destroy property. We served a guy, I remember, who I always kind of air quote broke a Subaru. He was doing really well, and we'd finally gotten him in public spaces and fairly calm. And after months of working with him and his team, and one time he just ran out of a restaurant and went out and beat somebody else's car, a lot, tens of thousands of dollars of damage. So yeah, these are the people who have been in crisis for years and whose families are in crisis because they just don't know what else to do. That is our most common referral at different START programs around the country. I don't know if that answers your question, Jill.
Yeah, thank you, Karen. Appreciate that.
Hey, this is Jackie, and I'm just kind of piggybacking off of that question. There was a talk regarding stabilization coming on average between 8 and 9 months, correct, with the START program. So what would you define stabilization as? Is it just a reduction by a certain percentage of the initial crisis level behaviors, or is there some kind of metric level that is a general goal that you guys are looking for stabilization?
Right. So when we think stabilization, we think at least a month or 2 with no crisis calls to us, which means the person has not met their own personal definition of what a crisis is for them. So we work with teams to identify what is a crisis for your family member or this person. And teams call us when that happens. So it's not, and also we don't just wait for people to call us. We are continually reaching out and ascertaining that things are okay and the person is doing well and doing better. We are starting to gather some information on that positive side around achieving goals of Perma. So again, not just stability, but actually thriving in their lives.
Great, thank you.
You're welcome. Okay. Thank you, guys.
Thank you, Karen. So I'll take over now. I want to talk about how we implemented the START model into Tennessee. So as Karen kind of gave you the overview of the model, I'm going to tell you how we're applying it and what we've done to be what I see as successful in the application of the model. So
Hey, Michelle, it's Jill. Can I have you just
Yeah.
move a little closer to your mic?
Yeah.
Yeah.
How's that?
That's a little better. Yeah, I think the closer you are,
Okay.
the better. Thank you.
I can always talk louder too, so I've
No, that's
been
already
known
better.
to be able to get very loud if need be. So I just want to share that DIDD, which is the Department of Intellectual and Developmental Disabilities in Tennessee, we are a state department that is operating the START model. We're a little unique. There's not too many START programs out there that are under a state department, but I think it has really benefited our ability to operate. We are obviously in collaboration with the Center for START Services in what we do in Tennessee. But I like to start this presentation just talking about the justification for why we brought the START model to Tennessee. And for those of you on the call who are not from Tennessee, hopefully this will be kind of helpful in comparison data as well. So I always start anytime I'm talking about what we do at TennStart with data, because we like data. I'm a BA by trade also, so we like our data. So this is a very small sliver of Tennessee crisis data. I try to explain this by saying this is fiscal year 21 crisis data for individuals currently enrolled in our Medicaid waiver services within Tennessee. We actually have two different side-by-side Medicaid waiver services currently in place. So the ones that are under DIDD have around 7,000 individuals receiving those Medicaid waiver services. This does not include the current open waiver service system that has around 3,000 plus individuals in that. Does not include the 130,000 plus individuals with intellectual disability in the state not currently receiving services, or the several 100,000 with developmental disabilities in the state not currently receiving services. So when I say it's a small fragment of the data, I really mean it. But you can even see still with that, with just looking at this is a group of 7,000 individuals receiving services for one fiscal year, which is, end of June to beginning of July. There are quite a few interactions with law enforcement, interactions with mobile crisis, who's our mandatory pre-screening agent to determine if inpatient psychiatric hospitalization is necessary, actual admissions to inpatient psychiatric hospitals. So that's quite a few for what is a very small portion of the IDD population in our state. I do have data from the Department of Mental Health, because that's one of the benefits of being a state department is we can get information from other state departments. So we actually had them pull for the same fiscal year 21 data for the IDD population as a whole. So just to kind of give you an idea of how frequently this is happening for the entire state's IDD population, 4,560 mobile crisis assessments were completed on individuals with IDD for this 1 year. 1,633 of those resulted in psychiatric hospitalization, and over 1,000 of those involved law enforcement. So individuals with IDD in our state are most certainly interacting with the current crisis system. So I want to give some information about what our current crisis system looks like in Tennessee, because I know this can vary pretty widely from state to state as well. So we have mental health hospitals. We have both private mental health hospitals and state-operated regional mental health institutes. There are definitely gaps and barriers, as I'm sure is a problem across the nation with mental health hospitals' capacity to support individuals with IDD. In our state, our regional mental health institutes that are state-operated, they are generally reserved for individuals who do not have another payer source. So for our Medicaid waiver service recipients, for example, they are sent out to private psychiatric hospitals if an inpatient hospitalization is needed, because they have funding, right? So they have Medicaid, they have managed care organization funding, whatever that payer source is, that gets distributed out to be utilized under the private psychiatric hospital system. A lot of those, as you can imagine, have limited capacity to support this population. So there are a lot of barriers and gaps in our current crisis system. Even still, even with us, here and making an impact, there's still gaps and barriers for this population. Mobile crisis, like I said, that's our mandatory pre-screeners. They're the ones who evaluate whether an inpatient setting is necessary, based on the factors that they evaluate to determine, is the person suicidal, homicidal, or are they a severe risk to themselves, those sort of things. They do receive very little IDD training historically, as well with the mental health hospitals. So there's a gap there as well, as you can imagine. Often, they're kind of at a loss with, how do we modify things to evaluate this person who's unable to communicate with us verbally. Just little pieces like that just put a real kind of stick in the system, and being able to make sure that people with IDD have access to appropriate services and necessary services. Professional clinical services that can include everything from behavior analysis. It can include psychologist therapy, any other type of therapy, occupational, physical, speech. So those are all professional clinical services. We have a good amount of those professional clinical services available. Certainly the ones who are more common to the IDD population have the capacities to support the population. Behavioral health benefits. For us, we have 3 managed care organizations under our big umbrella Medicaid services of TennCare. They have behavioral health benefits through the managed care organizations or through commercial insurance that can include everything from residential treatment centers to intensive outpatient services, psychological testing, those sort of things. There's a lot of behavioral health benefits available. Not all of those providers of those behavioral health benefits have the capacity to support individuals with IDD. So that's another kind of gap in our system currently. The DIDD, the state of Tennessee, operates 3 behavior respite facilities. So that is a short-term stabilization facility. People are typically there for about 2 weeks. We have 16 total beds across the state, 1 in each of our 3 grand regions. We are primarily using, I will say historically, we've primarily been using those post-hospitalization. So people who are being discharged from whether it's an emergency department or an inpatient psychiatric hospital stay, and they still need a little bit more stabilization, or the caregivers or providers taking them back need a little more time to prepare. Those have primarily been used for that purpose. We, as part of what START is doing, which I'll get more into detail about later, are actually going to be collaborating very closely with both the behavior respite providers and the Harold Jordan Center, which I'll talk about in a second, to enhance the therapeutic activities and process that they currently have, and work very closely alongside the START team. But I'll talk about why in a little while. I just wanted to touch on that piece. We would like to use them more as a diversionary option when a psychiatric stay or an ED visit may not be the appropriate move for that individual. We also have the Harold Jordan Center. That is a state-operated facility as well. It is intensive temporary residential service for people with behavioral health diagnoses. We also have a forensic assessment unit. So anyone who would be court ordered for a competency eval or found committable by the courts who has an IDD diagnosis, it's utilized for that as well. That's a 24-bed facility. Have a great interdisciplinary team there at Harold Jordan Center, and some comprehensive assessment procedures and some effective stabilization of more severe behaviors that have not been able to be managed in a community setting previously. There are certainly, gaps to that process as well, just in terms of, nationally, there's a direct support staff shortage occurring. So, I mean, we face those same things in both our respite center here at Jordan Centers, and also just, continually enhancing those services to make sure that they're truly effective, and doing what they're intended to do. The ECF, which is Employment and Community First Choices, is the other waiver that is currently open, the Medicaid waiver services in our state. They have two benefit groups, Group 7 and Group 8, which provide more intensive behavior services. So I like to include those on here because those are kind of the highest level of support available within our current Medicaid waiver services. We also do quite a bit of clinical consultation and education. Our department, DIDD, does, as well as other departments, the Department of Mental Health. We provide a lot of consultation and education surrounding IDD resources available, that sort of thing. We're going to be pumping that up as well as part of the 10 Start initiative, but I'll get into that. And then new to our current crisis system is 10 Start. So that's kind of what I'm going to touch on more in coming slides. So, as Karen touched on, 10 Start is a statewide resource for individuals with IDD who have complex behavioral or mental health needs. It was very important to us when we implemented this to have statewide coverage. Karen touched on how the model focuses on making sure that where you live doesn't impact these services you have available. And we wanted to embody that as well. In our leadership, our governor is very big on making sure rural areas have access to the same services, and making sure they have access to the services that they need. So we have complete statewide coverage across Tennessee, every single county, and there are more than 90. We have 5 total teams for 10 Start. And we've broken the state into 5 regions based on the centralized city locations. So I'm not going to spend too much time on this, but I did want to share with you our statewide coverage and how we broke those regions up. Our regions were based on mobile crisis call volume for the fiscal year when we were developing this program. So we looked at that mobile crisis call volume data that I shared earlier, specifically for the IDD population, and based the number of counties and the areas to try to even out what we were projecting as the potential need for crisis services across the state. And then I've also identified where our 3 therapeutic or behavior respite facilities are in the Harold Jordan Center here in Davidson County, Nashville as well. So getting into our objectives for 10 Start. These are going to line up a lot of with what Karen covered, but biggest thing is greater involvement in crisis stabilization. As I said before, we have mobile crisis, which is our mandatory pre-screeners who come out and evaluate a crisis situation and determine what services are needed. There was not a lot of training related to IDD for this population for mobile crisis providers. A lot of times they were at a loss. A lot of times, the evaluation may or may not get done. They may just get transported to the ED so that further, evaluation can be done. There was just a lot of gaps in it, and we really needed something specific to IDD. We wanted a team of people who are very well-versed in IDD, very well-versed in the IDD system to be the ones responding to crisis. So the START model and what our objectives were for fixing our crisis system for the IDD population very much lined up. And one of the best partners we could have chosen, and obviously an evidence-based model never hurt anybody. So we have 24/7 crisis response, like Karen said. We do respond in person. as quickly as possible. Our aim is to get there very quickly. Sometimes, as you can imagine, with statewide coverage, there are certain areas where we have to kind of problem solve, provide more support and consultation via phone while we are en route, but we do respond in person. We take that crisis response, as Karen mentioned, as an opportunity to really learn what's going on. We do very well to approach it as a human. We want to approach everybody in there as a human. The whole system's typically in crisis. When these things occur, from law enforcement trying to figure out what to do, from caregivers being very stressed and shaken from the situation, and the person themselves obviously has been impacted if they are in crisis at that moment. So our goal is to come in and not join the crisis, but to kind of try to help stabilize the situation and then come up with a plan to maintain that stabilization. So that is what we do in our 24/7 crisis response. Anyone who's enrolled in 10 START services, we start out with the START models intake process. So really getting a comprehensive assessment of those biological, psychological, and social factors that Karen touched on, really trying to figure out everything going on with that person and with their surrounding system that may be contributing to their destabilization. We take all of the tools and documentation and meetings together with that system and pile all of that into that cross systems crisis prevention and intervention plan that Karen touched on. It really kind of becomes the roadmap, and it is a living document that we are always modifying when we need to. But it has, it's a strength-based approach of a model. So it has the person's strengths on there. It has their abilities on there. It touches on if that person has a trauma history. It touches on vulnerabilities they may have from their mental health diagnoses or other things they've experienced in their life. It touches on what the environment looks like. So what, if you're coming into, because our team, we respond as a team. You're not necessarily going to get the person who is assigned to that individual responding. It's going to be somebody within that regional team. So we all are very familiar with each other's teams, but it always helps us, and it helps emergency crisis services and first responders to know exactly what that environment looks like that they're coming into. Is it a residential area? Do other people live with them? So that kind of information is built into there. And then there is a hierarchy of intervention that comes at the end of that crisis plan. So it starts identifying early warning signs, triggers, vulnerabilities, interventions that we have determined based on all of that comprehensive assessment that we've done. It tells you who to call, when to call. We like for the 10 START team to be at the very top of that early warning signs of destabilization. Call us in early so we can help prevent escalating to a higher level of intervention, right? We want to avoid unnecessary police involvement, unnecessary emergency department visits. But we're also there to kind of help determine, what level we're in for this person. Do we need a higher level of intervention? Are we in need of an emergency department visit for one reason or another? Helps us to be there to kind of make those decisions. And bring in other parts of the system as we need to do that. As Karen mentioned, we stay involved. Our goal is to keep the person in their community setting in their home as often as possible. But if for some reason it's determined we need to go to the ED, we need to get a mobile crisis evaluation, whatever that looks like, we are there. We are communicating with that mobile crisis provider. We are communicating with the emergency department staff, the nurses, whomever we need to communicate to make sure that they have appropriate and accurate information about that person. They have information about our hypotheses of what's going on in that situation. So just to give you an example of what that might look like, if we know a person is destabilized and it's not the typical presentation for them, and we have a hypothesis that there may be something medical going on, maybe there's a dental issue that needs to be looked at, maybe there's an infection, maybe they're constipated, that's a big one. We might ask the ED, say, hey, we need a KUB to really kind of look at their gut and figure out if there's a constipation issue so that we can rule out some of those medical causes that can cause people to destabilize pretty quickly. So that's part of what we do, is communicate with that system wherever we have brought them to. We go with them. We try to give the staff there strategies to kind of de-escalate them if needed. We make sure they have our crisis line in case they have a problem and they start to escalate in that environment. We can respond there, and we start being involved. So if, for example, they're in an inpatient psychiatric hospital, we are involved with the treatment team meetings. So we are involved with the discharge planning. We are involved with the caregivers to make sure there's a plan for when they come back, and that any changes to that crisis plan or the environment have been made to make sure that that's as successful as a transition as we can. So we really kind of provide a wraparound for anything that is not anything taking them out of that community placement, with the goal of getting them back into it as quickly as possible and as successfully as possible. So that is kind of the breakdown of what we do on an individual level, but I do want to touch on what we do on a systemic level, because I think that is equally as important. So the clinical consultation, education, and training that is part of the START model is really kind of blowing up, making sure that different parts of the system not only have training on what IDD is, but how they can better support individuals with IDD. So we do clinical education team events in each region. We'll be doing once we get to phase 2. I'll talk about that in a second. Clinical education team events where we bring different parts of the system together and provide a de-identified case example, educate on a theme around that case, give that opportunity to bring, the mobile crisis providers, local law enforcement, clinicians, hospital leadership. We bring them together in a room, and we provide this education and training, but it also provides an opportunity for them to communicate with each other, to identify those systemic barriers that everyone seems to be facing, and to educate each other on what their limitations are. So law enforcement has limitations on when they have to arrest when they're involved. So things like that, being able to have that opportunity to communicate with each other and come up with action steps on how we work better together is a really big part of that education and training opportunity. As part of what START does as well, we do formalized network building. So these are the linkage agreements that Karen touched on. We tell everybody, I feel like I do this presentation 80 times a day, but we tell everybody from the rooftops as loud as we can, here's what 10 START is, here's what we do, here's how we can help. So we meet with all parts of the system, whether it's crisis system, the IDD system. We try to touch on as much of it as possible. We meet with different parts of the system, tell them what we do, talk to them about partnering together with us, so that it's really kind of a handshake agreement on how we can work effectively together. Here's what we'll do for you. Here's what you can do for us in terms of getting us access to, who we need to talk to in an emergency department, for example, or being connected to law enforcement leadership so that we can contact them when we need to, having partnerships with psychiatric hospitals, some of those private psychiatric hospitals, so that if we need someone to have an inpatient stay, we have a relationship where we can at least try to push and say, hey, look, we've evaluated this. We really think this is necessary, and here's our objectives for that stay. So putting all of that in a non-contractually binding agreement, just to put on paper how we can help each other, is what we do as part of our formalized network building. And I'll kind of share where we are with that in a little while, but that's a very big piece of what we do and why it's effective. We also do systemic analysis, consultation, and reports. So we do that we do that both on a formal and informal level. So we've done formal systemic evaluations where we've had START hold feedback forums, collect data on a specific area. So for example, we had one initially when we launched related to our behavior respite programs in the Harold Jordan Center. So what's working, what's not working in relation to how that service is being provided. And then they collect all of that data, put it into a report for us, and then it allows us to develop action steps on how to enhance those services. We also do informal systemic analysis in that every time we have one of those partnership meetings for the formalized network building, we ask, what are the barriers you're facing with relation to the IDD population? what is it that you need from us? What training can we provide to you? And how can we better support you to build your capacity to support this population? So that's all kind of wrapped into that formalized network building and systemic support. I do want to touch a little bit just on an operations side in some of my next slides, so you guys can kind of see how this works. Make sure I'm doing okay on
Michelle,
time.
I just wanted
Yes.
to stop in real quick and just
Yeah.
give like a 5-minute countdown. It's 12:50 and we have Amanda
Yeah.
coming in after that. So just wanted.
I can do that. I've been told.
Q&A afterwards.
Yeah, I've been told I could read the fine print on the commercials for drug side effects anytime, so I can speed up. It's not a problem. So currently we're doing a phased rollout of the program. Just briefly, I want to touch on, we did a phased rollout. We want to make sure that this is effective and that we can walk before we run. So we really wanted to make sure that we were implementing the START model with fidelity, starting small, and then growing as we improve our capacity as a START team. So just starting with small caseloads, starting with only doing the 24/7 crisis response for individuals on a START caseload, limiting our eligibility to a smaller group of people. And then we're going to be building, which I'll share this PowerPoint so you guys can have it, but we're going to be building those caseloads. We're going to be building availability to other parts of the system to get this service. We're going to be amping up the community clinical education team events in phase 2. In phase 3, we're going to start picking up the waiting list for those who are waiting for services in the state so that we can make sure that we're providing that to them. The other big piece that we're going to be doing in later phases is we're going to be adding 24/7 crisis consultation for our partners and then also all emergency and crisis service providers so that we can work alongside them anytime they have an individual with IDD or suspected IDD and provide them with resources, do emergency referrals if we need to 10 start, and really just work closely and alongside with them to make sure that they have an IDD expert at their disposal whenever they need to 24/7. Our phase 5, our big end goal is to make this available to anyone over the age of 6 in the state who has an IDD diagnosis. This is our org chart. I'm not going to spend any time here. It lines up with what, what Karen talked about with what a START team looks like, but this is just the names and regions. We have clinical team leads and 4 facilitators who actually are coordinators who have caseloads in each of our 5 regions and plans to expand that. So where are we now? We launched 10 Start on July 1st. We are accepting referrals. I like to tell people where we're at. We're at 130 referrals to date since July. 76 of those are currently enrolled in 10 Start services on a caseload. We are operating 24/7 crisis response in 3 out of 5 regions. We had some staffing issues in 2 of them, which we are correcting and retraining right now to get that crisis response statewide. We received annual state and federal funding for our program through 10 Care, through the governor's budget. Our legislative team is very on board with what we're doing, and we had to do a lot of advocacy, obviously, to get that done. We also, through some of our partnerships, have grant funding, such as from the Council on Developmental Disabilities, who provided funding for our first year of START training. As Karen touched on, all of our staff go through very extensive START training with the Center for START Services. It takes up to a year for most people to be certified. It is a whole lot of training. It's like drinking from a fire hose. That's how they define it. So I will say that they're very well trained, and that training does not end. They are lifelong learners. It is an apprentice model, so we are constantly adding to the training and information that they have. We have an advisory council, like Karen touched on. We've had 4 meetings up to this point. We've got over 30 stakeholders from various backgrounds, including families and parents in different parts of the system to give us feedback. And that has been an amazing asset to our system. We are constantly evaluating our system, like I said, informally, but we did have that systemic analysis that resulted in our plans to add 3 10 Start Resource Center locations, which are sort of kind of similar to behavior respite, but more therapeutically enhanced. And then working very alongside training and collaborating and enhancing the existing behavior respite locations. We are continuing our collaboration and support with the system, like I said, to identify those gaps, establish those partnership agreements, and offer MHIDD training. I do want to spend just a minute here to talk about some of the
Michelle,
things.
we
Yeah.
really are over time. I really need you to wrap it up as quickly as you can.
This is my last slide.
Okay.
I just wanted to touch a little bit on some of the work we've done with the systems, which I think is something that Jackie wanted me to touch on for this. So we train law enforcement through the crisis intervention team programs that are, law enforcement trained on mental health. We make sure there's an IDD component to that. We have worked with the DD Council to develop an emergency room stabilization protocol specific to IDD, some of the systems work we've done. We do systems debriefs with hospitals and other parts of the system that we engage with to say what's working and what not working based on this person who was just there. So we do a lot of systemic work that's very important in helping us to improve what we do and improve our system as a whole. And then we are offering quite a bit of training out there to the system as well. So I apologize for going over time. I do want to say that we have an amazing number of partners for 10 Start. We have partners through all mobile crisis providers, over 24 hospitals, 9 inpatient psychiatric hospitals are part of our partnership, all of the managed care organizations, other state departments. So it's really been a great venture for us. I'm going to provide you our website in the chat box as well, if you want to learn more about what we're doing in Tennessee, but also just to say, anyone can contact me at any time if you want to learn more about how we did this, and I'm happy to provide that. So thank you all.
Okay, Jackie or Amanda. Amanda, do you
Yeah.
want to just go right into it?
Yeah, Amanda, please just jump right in. I'm sorry, go ahead.
Amanda, you're on mute. All
I
right,
was
take 2.
talking to myself. Welcome to the afternoon or mid-morning, regardless of where you are in our country today. So I'm going to take us back a little bit. This was such an amazing presentation so far, and we're going to kind of talk broadly about behavioral crisis, the etiology of it, what the current data are telling us from families, caregivers, and crisis responders that we've surveyed in our area. And most importantly, how we formulate one cohesive lens by which we can advocate for what I think is the most essential component, which is a full continuum of care for those individuals with severe and profound autism who experience behavioral crisis. And if people don't mind, I'll even give my own little introduction so that you know where I'm coming from and who I am today. So I'm a doctoral level behavior analyst. I've done almost all of my training in behavior analysis across a variety of very intensive residential programs and hospital programs, as well as state level work trying to reduce crisis situations for individuals with autism and their families. I'm a faculty at the University of Rochester Medical School and Medical Center. I came here about 2 years ago for this reason. They literally posted a faculty position to say, help us figure out why individuals with autism and intellectual and developmental disabilities are experiencing so many crisis events. And what can we do to help these patients, help these families, and ultimately help the hospital be able to better care for them. I'm a sister of a man with autism, and I always think that's important to share because I often feel that unless you've walked in those shoes, I'm not a caregiver, but as a sibling, I think we own a lot of that responsibility, especially as our siblings grow up and we also can become primary caregivers. I am very passionate about this, to see children and adults come to our ED in crisis to see what their families go through, and to see them not have a safe disposition plan is heartbreaking, and I feel privileged to work with those families. And I'm also a person who doesn't accept being told no, like many of you, I'm sure. So the issue at hand, and I actually saw someone put one of these articles in the chat, so you beat me to it. But we are continuing to see that even with the development of new programs, even with the magnifying lens put on this issue, we continue to see dissemination and publications that tell us that individuals with severe autism are languishing in hospitals, are utilizing emergency services, awaiting some program, awaiting support, and there's absolutely nowhere for them to discharge to. And I pulled these just from recent publications that I Googled from the last few months. So this is honestly a very tiny snippet of what is actually happening out there in the world, and I'm guessing in your state or your communities. So who we're talking about today, just to set context, are children, adolescents, and adults with autism, most of also which have IDD and experience either a mental health or a behavioral health crisis. And for today's talk, I'm focusing on those individuals with severe or profound autism, because we know that the social, developmental, and cognitive challenges of this subset of the autism population is increasing the probability and likelihood of someone experiencing an acute crisis event. I'm also here to talk about the caregivers of those individuals I have already defined. And who are the families? Well, from what I know of you, and not to make assumptions, but again, I've had the privilege to work with many of you and those your children, are that you are dedicated advocates for your children. You have often sought out experts and expertise locally, nationally, or both. You have tried the things that you were told to try. So, these are not situations I'm finding that requires a behavior plan or, a new kind of look at what the triggers are in the environment. That's not the situation we're talking about. And I think that when families experience that kind of, we're just going to do another behavior plan, it really minimizes the complexity of what you're managing, what you're dealing with, and who your children are. Because most importantly, I know that everyone I'm working with is looking to ensure that their child, themselves, and their families are safe, and most importantly, are able to move forward toward as much independence, stability, and happiness that they can achieve in their life. And that's really the focus of this today. So, Jill, you actually asked in the very beginning when Karen was with us to define a crisis. So I looked, in the dictionary for what a crisis was, and then I looked at some models that have looked at crisis for individuals with autism to define some aspects of crisis and emergency for us. So I'm going to walk us through this to help give a context to what I'm presenting. So in the dictionary, a crisis is a time of very intense difficulty, trouble, or danger, a time when you have to make a difficult or important decision. But I put in this iceberg because I think every single one of us who either live this or work in this know that a crisis or an emergency is actually just the tip of an iceberg. And under the water, there are so many challenges on a day-to-day that are swirling and bubbling. And it's only when that, kind of point of crisis develops and goes above the water that the attention is brought to it. But it doesn't mean that before the crisis or even after the crisis moment that those challenges are not still there. And I looked at some of the literature on crisis situations for individuals with autism. And when we start talking about services, I think it's really important that we collectively discuss crisis versus emergency. Now, you may or may not agree with this definition, and I fully support, recognize, and respect that. But I think for today, I'm going to try to stick within this just to help us do some delineation of service models. And of course, if you have feedback on that, I very much want to hear that as I get to the end of this or after, if you want to email me. So when you look at some of the literature on, crisis situations for individuals with autism, they break out the fact that an emergency is typically a relatively abrupt and sudden situation in which there is an imminent risk of harm. So risk of suicide, physical harm to others, states of seriously impaired judgment in which the individual is endangered, or risk to a defenseless victim. So I can think of many of the individuals I support and their families and points at which they have absolutely been in an emergency situation, right? They have met one of these criteria. There is imminent risk. But even when there is not an emergency, a family or an individual can still be in crisis, and it still deserves the same amount of attention, if not more, right? A crisis is by definition a loss of psychological equilibrium. It is something where we are seeing a proliferation. There is an issue that lasts longer than the emergency. It may have a slightly decreased risk of danger, but a crisis is going to lead to an emergency situation if it is not reconciled and it is not rectified, okay? So for the content of today, we are going to touch on emergency services, but we're also going to look at the crisis situation and what kind of models are going to help us prevent and respond to a crisis. And things like START come into that for sure. When we're talking about services for emergencies or crisis, I think one of the biggest challenges that struck me as I was writing this talk was how much they vary greatly by state. Even if you have, and Michelle, I'm sure we've kind of touched base about this offline, even if you have a similar program, a hospital program, an outpatient program, an ABA program, a START program in your state, my guess it's going to be varied depending on who your clinicians are, how the state funds it, right? And what is actually available can vary greatly by state as well. So sometimes we're going to see all the things and sometimes very few. So generally, when we're talking about emergency or crisis services, we're talking about some kind of mobile crisis team that can be a crisis team or an emergency service. We're talking about our police officers, our ambulances, our emergency responders. We can be talking about in-home family support services, our emergency departments within hospitals, inpatient programs that provide acute care, respite programs, or even stabilization programs. Those are collectively many of the services in very general terms that we tend to think about when we think of emergency or crisis services. Here's the problem though, and this is what I've learned from many caregivers and having done this work over the last few years, is that even when we have those things, okay, there are very limited service options compared to the need. The scope of the problem, that under the water iceberg, is not well understood for those we're talking about today, for those individuals with profound autism. And a lot of the time, those crisis services fail to address the underlying issues that actually resulted in the crisis, right? That's when I hear a lot of, we were told to do the behavior plan, or we were told to go look for this one, medication, when those of us, I believe, on this call today know that that is not going to be the answer. These are very complex issues that require a complex interprofessional stabilization program or team that is going to help us resolve those crisis events. Another problem is that there often fails to exist an integrated continuum of care model to prevent and then address crisis events. So at the end of my talk, I'm going to go through what a continuum of care is and why we should all be advocating for that versus just pieces of a puzzle. There is very frankly often a discrepancy and misunderstanding of the etiology of the crisis for those with profound autism. And there is a lack of ongoing state-funded supports to stabilize an individual if they do require a higher level of care. In addition, there are a lack of residential respite and other higher level care options. We have a shortage of specialized providers that understand those individuals that we tend to work with or have in our families. There are not many supports for family members who are also experiencing the crisis themselves. Care is often siloed and fragmented. For you family members who have a provider perhaps in the community that understands your child, to then have to go to an emergency department and you be the ones to tell what the behavior plan is or what to do and what not to do is, I think demonstrative of highly siloed and fragmented care. That is not the thing you should be having to do during a moment of crisis. Yet for 90% of individuals, that is what you have to do. And that is incredibly unfortunate and even adds more to the crisis situation. There are reduced options as an individual ages, which increases the probability of crisis events. And this last point I bolded because I think this is actually one of the most important things. There are many groups, agencies, stakeholders, and advocates who try to solve this issue, but I don't think many are good at working together to define and advocate for the same outcome. So I am going to show you what I think a model integration of problem solving looks like that has been done in the state of Massachusetts. And I'll be happy to share the reference and the actual documents when we send out the slide, if that would be helpful. So I'm going to jump a little bit into the etiology challenge while also just being very mindful of time. Just like Michelle, I'm very passionate about this, so I could talk about it at length. So there is a huge difference between a mental health crisis or a behavioral health crisis. Just because someone is having a mental health crisis does not mean they're having a behavioral health crisis, and vice versa, okay? There's also a very big difference between the emergency services and crisis services based on those definitions that I talked about, right? And it's also very different what an emergency service can do and what a crisis service can do. We also often get mixed up for the individuals we serve in what service systems there are to best support our individuals. So we find this a lot in New York, right? When someone has both a developmental disability and a mental health challenge, and they really require specialized services that understand both developmental disability services and mental health. That integrated service line is very challenging. You tend to be said either you belong to one system or the other. And if you belong to this system, you can't get services from the other system. That is hugely challenging. And we really need to be thinking about creating more collaborated and shared service lines for this population. And that brings us down to what the appropriate treatment is for this population. So I'll talk about this with the continuum of care, but there have been a number of studies that have actually looked at where mental health services miss the mark for individuals with autism, and where autism services can be more inclusive of mental health services. So if you're looking for an example of inpatient units, for example, if you're very interested in understanding why inpatient psychiatric units are not appropriate necessarily for your child with profound and severe autism, and you're saying, well, then what is? Look at Matthew Siegel's work. He runs some inpatient programs called Springbrook, and he's going to, have a lot of research that really distinguishes the difference. We need more of that. We need more people to be able to delineate what the difference is between mental health and developmental disability or behavioral models, and understand which you might need so that our children can get truly the right treatment based on the etiology of the crisis being experienced. This came out of an article I read, and there are, a bunch of kind of papers on the issue of emergency crisis. And this was a quote that I thought was really important. So Dr. Vasa is a psychiatrist from Kennedy Krieger. I'm guessing most people on this call are aware of the very intensive inpatient long-term stabilization programs that KKI offers. She noted that unfortunately, individuals with autism are showing up, as we know, more frequently at ERs, and that while they can have a psychotic disorder, at KKI, there is a notion, or at least a conceptualization, that this may often be a misrepresentation of the individual's behavior that occurs in the context of their underlying language, cognitive, and social impairments. And I truly feel that this hits the nail on the head in terms of why sometimes our individuals and our caregivers are often left spinning in circles over and over, right? Because this comes back to that iceberg mentality. There is no medication that is going to teach someone how to cope, how to functionally communicate. It may make it that a child is more likely to be able to access that instruction, but we have to make sure that the child or the adult is getting true behavior stabilization. That is very different than mental health care, okay? So that etiology factor is very important. And outside of those that really understand the world you're living in and that our team lives in, don't really understand this underlying language, cognitive, and social impairment for the profound community, okay? So this becomes important when you're going down this pathway of crisis and saying, what are my options, right? Well, in an emergency, we have certain options. We have our emergency responders. We have our mobile crisis teams. It's amazing to hear what Michelle shared about START being available in the moment. I do have on a slide that many mobile crisis teams are not available in person in the moment, and that's what a family needs. Someone that understands how to support their individual in the moment and not via phone only, or not with just general behavioral recommendations. We know we have emergency departments available to us, and sometimes we have acute inpatient. So if someone has an acute medical underlying issue that is, kind of creating the emergency situation, they may go to an emergency department and be admitted for medical observation or for medical treatment. Or if someone has an acute psychiatric diagnosis or mental health indication for a crisis, they may be admitted for an inpatient psychiatric stay. But I'm going to show you some data that actually shows how rare that is for our population, unfortunately. And then for crisis, that other situation, that kind of longer term, maybe less acute in the moment, but is more present and actually, I think, more problematic, is we have mobile crisis teams. We have things like stabilization programs, right? Like a KKI, which is actually a long-term inpatient stabilization program, not an acute hospital setting. Those are very different treatment models, okay? We have intensive outpatient programs, intensive in-home programs. We have intensive care coordination. There are presumably options, but the challenge is we can't always get to them, or they don't exist when we need them. And they also vary in terms of whether they exist in our state. So some of the other barriers that I have heard or seen for patients, or I've heard from families, is that first off, there are not people that know how to adequately understand what the right psychiatric or medical diagnosis is, and therefore what type of stabilization is needed, okay? There is often a failure to stabilize with intensive behavior support in teaching. Yes, I am a behavior analyst, so obviously I tend to go down that route, but I'm lucky to work as part of an interprofessional team here at the medical center. And I have heard time and time again, kind of the challenges that if you fix the kind of medication pieces from a psychiatric perspective, or you remedy whatever the medical challenges are, we still have all of those social, communicative, and developmental challenges that ultimately were one of the predominant reasons for often entering that crisis situation. One of the biggest things I hear is that there is often a lack of adequate staffing support in the home environment, wherever that may be. So for most families who are experiencing crisis events, simply trying to kind of move us past the emergency or the immediate crisis and say, now we can just go home status quo, whether that's a family home or a residential home, that's not going to work, right? The amount of care and staffing support it often takes to implement what your child may need in those settings is well more than what is currently available, if any at all. Services that respond to crises are, as I mentioned, not available in person frequently at the moment. A huge challenge for individuals and families is having to own and tell their story over and over and over, which I think shows the issue of the siloed and fragmented care. Fear of how a community responders or an emergency responder or medical setting will respond to you or your child. And then a misunderstanding of resources. I think it's very challenging when a family goes to the emergency room and is told you just need this different medication when someone else tells you something very different. When people don't understand the etiology of a crisis event for those we work with, it can be, I think, very disenfranchising and disheartening to kind of go back and not receive any new information or support. So what I'm going to show you today is how we first look to understand the scope of the crisis. Because here's the thing. I came here and I felt very strongly, we're going to build programs. We're going to build the right types of service models to help families not experience these events. But what I learned is that without subjective data, without being able to look at the picture whole scale, it's very hard to get stakeholders on board. So I want to show you some modeling of how we did that and help you to understand kind of where in our region we're seeing the issues to help move forward with advocacy. So what is the scope of the crisis problem? What does an actual continuum of care look like? How do we advocate for multi-system support to get this kind of continuum of care, of which programs like START are essential as part of that continuum? And then ultimately, I know we don't have time for it today, but I would like your feedback on how to improve this modeling. You are the teachers in this situation to those of us who are doing the work. So one of the first things we did when I came here was, as part of my work with our USAID, was to understand what the experiences were of families and caregivers who were using crisis services in Region 1 of New York. I was hearing that we had programs. We do have New York START here. The new name is CSIDD. We have mobile crisis teams. We have some specialized programs that go along with our police officers. but I was still hearing families say that there are many issues here, that they weren't getting what they needed, that there was high recidivism to our emergency rooms. So we created a survey to understand what was happening. Got about 40 respondents, and half of those were crisis responders, folks from mobile crisis teams in New York START, and half of those were family members, autism self-advocates, as well as many others. And again, I think I already told you why we wanted to complete this data analysis, but again, stakeholders and leaders in our states, in organizations, in our regions, just really fail to sometimes understand the gap between what they're doing and the experiences of those who utilize services. And we need to articulate how the current services are or are not addressing challenges. We also need to be able to tie the data to social, fiscal, and health equity impact. Those are the pieces that are going to be really meaningful to stakeholders when you're trying to make change in your state or in your region. Most importantly, we have to be able to show cost savings and increase health equity by reducing domino effect. So those are the things I came to this data analysis with. And there's one other I'm going to show you momentarily. So I walked you through what some of our services are, just so you knew the context, because there are a lot of services in the region I work and live in, yet we still have individuals coming to our hospital system repeatedly, adults and children, experiencing crisis events, living in our hospital for hundreds of days because there's simply nowhere to go. So when we break down the survey data, the first thing we ask is, well, what is the reason you're using the crisis kind of response team, or what are the reasons you're responding to a crisis? So the most common one, and I'm sure this is no surprise to this group, was aggression. At 86% of the responders nominated that. Self-injurious behavior, outbursts, destroying property, and threats to harm self. Those were the most common ones. We did see some refusal, threats to harm other, running away, other lower level behaviors were listed, but the ones that were most predominant were the ones I think that many of you either experience for your family members or those you serve. When we looked at, well, what are the ages of the people that you're calling crisis services on or that you're responding to, we most frequently saw that they were adolescents and young adults, with children kind of coming up as a third category. And this is consistent with some other data from our hospitals I'm going to show you in a few minutes. So I really wanted to understand the perspectives on crisis support. So when we asked the teams, and we split this up, which is why you're going to see two different lines on this graph. Well, what kind of supports are you getting, or what kind of supports are you offering? We often saw that the crisis team responders were more likely than caregivers to say they were offering certain things, right? There were some discrepancies in some of the service areas. And I think that's important because both groups have valid opinions about what's happening. So what you can see here is that we have these kind of triangle shapes. And when the line goes above, that shows the increased responder rate of the crisis response team. So for example, behavior strategies. Crisis response team said that about 100% of the time, they were offering behavior strategies, where our caregivers felt that on average, only 60% of the time they were getting that. For environmental recommendations, we saw on average, the crisis team noted that they were offering that about 80% of the time, but our caregivers, were noting they were only getting that about 50% of the time, and so on. We had a pretty big discrepancy in the training and coaching. Even though it was generally lowly nominated, we saw families really said that about 0% of the time they were getting that in our region, whereas 40% of the time crisis team responders were thinking they were offering that. So this was really important because one of the big things we want to do is we want to create more parity, right? If we can give feedback to our crisis teams, just like, Michelle, you and Karen talked about how in Tennessee and with the START model, there's always interest in looking for feedback. This is one way I think to get that, right? How do we compare what crisis teams are offering to families from what a family in crisis is experiencing? Then we wanted to say, well, what are the areas of expertise? What do crisis responders note that their areas of expertise are? And then what are the families seeing as the area of expertise of the crisis members? We did see that there was strong agreement on the areas that crisis teams had expertise in. but that our crisis team members were nominating their expertise just a bit higher than the caregivers were. So we have here our caregiver responses in the dark blue and our crisis team responses in the blue. And, the three areas, and we had a number of different topics that crisis team members told us that they had expertise and training in that were on the survey. And we saw that the strongest ones were assessing mental health and safety, the characteristics of autism and IDD and the impact on crisis events, and just understanding why someone is engaging in behavior. And then we talked about training needs. And, we said to families and crisis team members, tell us what would be the most helpful. The number one thing was more training and support on challenging behavior and de-escalation techniques. Number one. The second was working with minimally or nonverbal individuals. So that resonates to this group right here. And I will tell you that I'm a part of numerous mental health echoes for individuals with autism, where we're trying to train more community providers. And this is the number one thing we get every single time, is working with those individuals who are minimally or nonverbal. And luckily, there are providers like us that know how to do that and feel very strongly that there are really helpful and accessible interventions for those individuals. But if that is still an area of need for our crisis responders, we need to hone in on that. Behavior and safety plan models was a big one. How you actually manage a crisis situation safely. Understanding family and system stressors was, strongly nominated by both groups. And then kind of that comorbid diagnosis of having autism, IDD, and some other mental health diagnosis, and how that creates more of a crisis situation. And then lastly, we said to the crisis responders and the families, what do you think is needed? Okay, what if these services were put into place would decrease crisis events for individuals with autism and IDD? And the top, I think, 6 that actually were nominated were residential opportunities and educational opportunities, more outpatient behavior treatment programs, and intensive in-home behavior supports. And then coming down the line over here were mental health opportunities and social opportunities. It was interesting because we didn't see huge amounts of people talk about inpatient behavior stabilization programs or inpatient psychiatric programs, which I had kind of expected. But we really saw that the families in particular, when I looked at the data separately, were asking for just more behavior supports, whether it's outpatient, whether it's in our home. We just need more. We need better educational programs. We do need mental health supports that know how to work with our individuals who have autism. And then we do need, as they age, better residential opportunities that are more easily accessible. So this was very telling because we are consistently hearing from key stakeholders in our state and region that there are efforts underway, that there are new programs being developed, but there are discrepancies between the help that a caregiver is feeling from certain programs and the experiences of those who are delivering the services. And caregivers are often telling us that, this issue of crisis is only increasing instead of decreasing. And they continue to articulate the models are not effective. The time to intervention does not meet the need. The intensity of the services is nowhere near the intensity of the crisis. And the inclusivity of those who have profound autism across the age range are not considered within the majority of these services. And I think those data, especially the training data and the discrepancy on the services offered, is one important area that we shared with our regional teams to be able to say, we need to do an improvement here. You have put a lot of time and effort into certain emergency services, but they're not meeting the need for the caregivers. The next thing we wanted to show our stakeholders, both at the state level and regional, is what was happening in terms of the hospitalization. Okay, so I'm going to go through this a little quickly because I do want to get to the continuum of care and make sure we have plenty of time for question and answers, but I'm happy to share these one-pagers with you and have a conversation offline at some other point. So if I'm going to get our hospital leadership or our state partners to support building new programs, like stabilization programs, outpatient programs, to work with a New York start, I need to know what's happening with the data. And, I think that that's sometimes where we struggle. It is really hard to pull data from hospital systems. So we worked as a system to do that, to understand for individuals with IDD, We did separate out individuals with autism within that. What are the trends and set in terms of psychiatric utilization for our EDs and inpatient programs? Who are the people coming? What is the treatment they're getting or not getting? And we've been doing some cost analysis to show cost offset would happen if we actually created more programs and supported a full continuum. So I separated this out, as did my project manager who worked through this data at length, our pediatric and our adult patients. So for our pediatric patients, we've seen that over the last 5 fiscal years, we've had a consistent amount of children coming to our psychiatric ED, as well as a consistent number of encounters. So the number of times they're coming is remaining about the same, and the number of patients is remaining the same, meaning that we're not really seeing a dent in the numbers from the current service lines. Now, there were periods of increase and then decrease, and with COVID, we know there's been some mitigation because people are afraid to go to hospitals. So we do expect, hopefully in the next year or two, we'll start to see what the real sort of data is. For our adults, we are seeing an upward trend in terms of the number of encounters, even though the patients are staying consistent. So we have the same number of patients, but they're coming back more frequently, which means that they're not getting adequate stabilization in the community. We wanted to know who the individuals are. So for our children, we're predominantly seeing adolescents and late adolescents come, predominantly males, predominantly white individuals. And 46% of the children that are coming have an autism spectrum disorder. The payer, and this is super important for us from a funding perspective, is a primary of Medicaid. And for those of you who live in New York State, we have had huge challenges with getting ABA reimbursed for Medicaid. So I will try to correlate that at some point as I work through our state advocacy efforts. For our adults, we are seeing a very different population. So we're predominantly seeing individuals between 20 and 29 years of age. So this is not going to be surprising to you. Those of you who have family members on this, we know that transition cliff, right? We know that as an individual ages, they get bigger, as school tends to kind of fall out and other adult programs fall in or not. We tend to see those crises occur, and this data reflects that consistently. We do still see more males, but not as high of a ratio as we did with the children. And the population in terms of ethnicity is somewhat similar. We did see a similar amount of autism spectrum disorder with more Medicaid prevalence here. And then we looked at, well, where are these individuals coming? Like, are they coming to our psychiatric ED and getting admitted inpatient or not? And why are they coming here? So here's one of the most important things. We found that for our children with IDD and our adults with IDD who are coming to our psychiatric ED, around 84% combined were psychiatric emergency encounters, meaning they were never getting admitted inpatient, okay? And that goes back to that etiology challenge and that appropriate location for treatment challenge, right? You know, we know that mental health treatment and behavior stabilization are very different things. The program KKI offers is a long-term behavior hospitalization. It's not an acute inpatient psychiatric hospital. So that these data are demonstrative of this. That doesn't mean these individuals don't need something more, but our current service lines do not meet the need. And I think that's hugely challenging, and I think very misunderstood both by healthcare and also by the community at large. We see that our children are often coming in for psychiatric evaluation, which basically means they had an explosive behavioral episode and people are not sure why. And then we see suicidal, aggressive is sometimes coded, but it's more the psych eval by our providers and so on. Whereas for our adults with IDD, we see a much higher prevalence of suicide being rated, with then that psychiatric evaluation and aggressive behavior kind of coming up secondary. We then looked at length of stay and recidivism, meaning are people coming back numerous times in a year? So we are seeing for our children, which is here on the left, an increase in children staying in our hospital for 22 to 50 days, 51 to 100, or 100 plus days. And you and I both know what that means. That means that these are children who have come to our hospital and cannot discharge safely. These parents have done everything that they possibly could do, and there is nowhere to go. And unfortunately, a hospitalization or boarding in a hospital can actually delay, at least in our state, access to higher levels of care versus speed it up. And the reason for that is because many individuals decompensate in the hospital because they are not adept at providing the behavior stabilization that these patients need if it's not that kind of program, like a KKI or a Springbrook that Matt Siegel has up in Maine. So I think that that's been hugely challenging for the hospital system to understand and for us to talk about with our regional folks who say, well, you know, they're not doing well in the hospital. And we're like, because this isn't a stabilization program, they need to be in an adequate program. They cannot discharge home safely. For our adults, we're not seeing the same level of patients increasing in terms of being with us for 100 or more days. We are actually seeing some decreases in length of stay, which is positive. But what I'm hearing from caregivers and group homes and residential agencies is that the issue and the crisis is just happening in the homes, and they're coming in and then being discharged and coming in and being discharged. So collectively, those data mean that 50% of children and 20% of adults who utilize psychiatric services in our system have autism. We tend to see the highest levels in those adolescent or adult years. They come for very different reasons. We're rarely seeing admittance to inpatient psychiatric locations. And we are seeing a lot more boarding for children with a slight increase in length of stay for adults over the last few years. So what do we do with all that information, right? Well, first off, some things I'm doing that I'm not sharing today is I'm creating some fiscal analyses to show cost savings or cost offset to the system in the state if we were to actually create other program models. And then we have to define what that is. We need to make sure that once we define it and get caregivers to say, yes, these are the things I need, these are all the things, that they exist in some way statewide or regionally, just like Michelle was talking about with START, and that we work with national stakeholders to ensure that funding is aligned to continuum models. And most importantly, we should expect that an individual may need at any point of their life a different level of that continuum of care, and they should be able to access it very easily and known. So guess what? This is actually not a novel idea. So in Massachusetts, there was a huge undertaking funded by the Children's Mental Health Campaign to actually look at this issue for children with autism spectrum disorders. And it defined what must be considered in a full continuum of care. Because if we just create an inpatient program without everything else, we'll still end right back up in the point of crisis. If we just have really amazing START teams and mobile crisis teams without the other pieces, we're just going to end back up in the point of crisis. So Massachusetts did this for us as a model. And I encourage you to look at this and then think about within your own area how we work to implement this. So first off, any pediatric or adult behavioral health continuum of care must consider environmental and developmental needs. The family are the assets. That's a whole different talk, but our families are our partners and our champions, and they are the ones who know what their children and adults need. Any system must be urgent and flexibly responsive and able to support the needs of someone who has underlying behavior health or neurodevelopmental vulnerabilities, exposure to trauma or adverse childhood experiences, adverse social determinants of health, life transitions or relationship stress, or any need that can destabilize a family system or the individual, which is really what creates the crisis. They have in the report what actually fragmented care looks like. And this is, very consistent within our state. So I can add, delays to residential programs or respite programs closing down or whatnot. But they show you that, here, sometimes you have the things, right? You have mobile crisis teams, you have outpatient clinics, you have an ED, you have an inpatient program, but there are delays, or they're not appropriate for someone with IDD or autism, especially not someone who is profound, right, in that way. And they're not responsive to that population that we are tending to see end up in a crisis situation. And then they actually proposed a full continuum model where a child with autism and urgent need has access to very specialized and enhanced service lines, enhanced mobile crisis intervention, PCPs with integrated behavioral health, enhanced clinics, an ASD, IDD behavioral health specialized inpatient unit, I mean, that's what many of us are talking about. We don't want to have to wait for KKI, even though it's incredible across the country for 2 years. We need those in each of our states, but then we need step down programs. You can't go from that level of intensity right back to your home unless you have some stabilization, unless you have very intensive in-home supports. That is what they proposed. And they're actually moving forward with implementation. And it includes behavior analysis. It includes master's level clinicians like START clinicians that know urgent care assessment, family partners, specialized psychiatrists, MDs, psychologists. This is what we need. We need to define and develop a full integrated care model across the continuum. Because here's the thing, the crisis is often bubbling. We often talk about this within our enterprise, that whether you look at my division, which is transitional care medicine, or developmental pediatrics, for every one child or adult that shows up at the ED, there are easily 50 or 100 more that are just trying to keep it together, right? With different services, trying to piece together supports, and with different sort of team members coming in and trying something different. But what we need is early intervention and engagement of services. We need very robust outpatient services that do psychiatric work, medical work, intensive behavioral work, which I obviously feel very strongly about, family coaching and support, and then in-home work. We also need acute intervention services that know how to rectify or stabilize the emergency situation. And that's where we get the training from the START team, the ability for the ED providers to know the patients, know how to ensure that they can assess, is this really an emergency? Is there something medical or psychiatric going on? And or what is the situation? How do we ensure safety and get this patient back home where they can get the outpatient support they need, or to an appropriate inpatient program? And then making sure those residential and inpatient programs are robust and have the support they need to prevent crisis events. The most important part of an integrated care continuum is that an individual shouldn't have to retell and own the story and experience more crisis and trauma because of, having to do that in addition to the crisis they are experiencing. So I'm just going to say that I know I gave a lot of data and a lot of general comments, and I am going to wrap up in 3 minutes to make sure there's time for questions, but we are piloting this here. So we do have very enhanced now integrated outpatient services for adults 16 and older that are behavior analytic, in which we partner with our medical providers, psychiatric providers. We also have just recently developed an inpatient consult service. It's not an inpatient unit, that is on my list, and I'm doing the work to get it. But we are working to show the utility of when you put really good behavioral services in as part of a team with medical, psychiatric, and other providers, what can happen for our patients in terms of stability. We are missing a lot of pieces. We're missing robust in-home supports. New York does not have the ABA service model that many other states do, like Massachusetts, or some of the mental health supports. But I think that what we need to do is continue to push and say, we need all the things, and not just say when we get one of the things, yes, that's enough. Because one thing, if we're missing one piece of this puzzle, the whole system can unravel. So I urge all of us to look at those reports and think of that full continuum of care. In the interim, I want to pause for a minute, because I'm sure there's many of you sitting out there saying, well, I have a crisis going on in my life right now. What do I do about that? And I really do wish I had the immediate answer, and I'll give you some more immediate things that Michelle and I have talked about, but that I also thought of. So first off, I encourage you as caregivers to articulate your individual needs in a clear written format. You have no idea how many times I work with caregivers who have come to the hospital with their child and they don't have a safe disposition plan, but they don't know what it is they're looking for. And I understand that, but think about what it is. Is it taking your child home, but with 24/7 behavior services? Even if it doesn't exist, write it. Is it a residential educational program? Is it a respite program for 2 weeks so you guys can just take a breath? I would really think about what are the needs long-term and what are the short-term needs. I'd write it down, because even if it may not exist, it's really good to have that written, to say to a hospital provider, a crisis provider, this is what we need. This is what we're going to need to be able to maintain safety. If you don't have a safety or a crisis plan, create one with your provider. Don't wait to go to the ED until someone is hurt. I know many of you already know this, and I'm preaching to the choir, but if you don't have one, do it, and share that with your local ER and ED. Find someone like me who really just wants to be your champion. And if you need help finding people, I'm happy to help you. And know what to expect. Call them and say, if I were to bring my child here with profound autism, worried about medical or psychiatric underpinnings, are they going to get admitted based on the situation? Are you just going to say no because they have autism? Try to talk to the people and try to understand what services may be available in your area. And I encourage you to connect with any resources available, even if you don't think they're going to fix the need. Even if a friend who's used the services has told you that it hasn't worked for them, it is so important to show that you have done all of those things because those people can also be advocates for you for next levels of services. Partner with agencies on data analysis and advocacy. We need your hospitals in your area to do this kind of work, to be able to get programs to be funded, and tell your story. You parents have the loudest and the best voices of all, and I encourage you to use those voices for even, with providers and with state level individuals. And then lastly, Michelle and I talked about some other, more specific things. I already said, tell your story, but I would recommend to be concise, to the point, and repeat it. I found that our legislatures and people who are making policy and funding have a very short attention span, and I like to talk. Support initiatives around CMS funding for stabilization programs and long-term care opportunities. They're very different than acute care things. Look to advocate for higher reimbursement rates for complex individuals, and then look to get and support things like the training for law enforcement that Michelle spoke of. Try to join public advisory groups or committees, identify providers that either will be your champions or need more training so they can do this work, and then work with your different payers to identify what's available, and if not, fight them. Thank you. I wrote here my favorite Ruth Bader Ginsburg quotes: fight for the things you care about, but do it in a way that will lead others to join you, which I think is something we do, all of us, on a daily basis. Thank you for your time.
Thank you, Amanda. Jackie, we're running out of time, so if you want to run through some questions for our wonderful panelists, that would be great.
Yeah, thank you, Amanda. Always such a breath. And what's so encouraging to me about you, Amanda, is you're just such, like I said, you're just such a fire, and you can feel the passion that you have for this, but you're also so confident and just intelligent, and it really gives me some hope as to how we're going to be shifting the baseline of what is actually even appropriate care for this particular demographic, while we now have professionals like yourself and Michelle in this field working to really change things. And that gives a lot of us as parents hope. And I personally, I don't know if any of the other viewers here can attest to this as well, but I personally even teared up at some places just at the validation of our experiences, which we really don't often hear. You really hit so many points just absolutely perfectly as to the differences between emergency and crisis services and mental health and behavioral health, and the complexity of all of it, and how that challenges us. So really, truly, thank you. It makes all of us feel heard. Even if we don't have perfect answers yet, it does definitely make us feel like there's some hope on the horizon, that there are people working really hard at these. So there's a lot of talk regarding Washington State and Texas, both, some Illinois. And so I'm really grateful that you shared about the steps and how to advocate, how to share your story. Will you guys be providing your PowerPoints or any kind of printouts so that we can share that with the audience afterwards? Yes? Okay, great, because that's been some questions there too. And Debbie Shutt says it sounds like a wraparound type program that is specified to IDD ASD. Would that be accurate?
Yeah, and I mean, Michelle, I don't want to speak for you, but I think that it's a continuum, right?
Right.
Like we need all the things. We need really well-adept residential programs. We need really good day programs. We need stabilization programs. We need outpatient services. We need START. We need START. And then we need inpatient. Like, we need to pivot and respite, like the Harold Jordan Center. I saw Laura, you asked about funding, and I want to know about that too. We need to hear about the good things and each start filling in our diagram. Where are the inpatient, or who's going to do that? Where's the stabilization? Where's the crisis? Where's the outpatient? And in our state, I think we need to force our legislators to say, nope, not just one thing. I want all the things,
Right.
because that's going to be the key there.
So Michelle, how is the Harold Johnson Center funded?
Yeah, the Harold Jordan Center is funded through a variety of things. It is state and federally funded. It is a state operated facility, but stays there can be funded both through our Medicaid Waiver Services program as well as behavioral health dollars from the managed care organization or private insurance.
Awesome. Michelle, I had a question too. During your presentation, you noted the data that you've collected on how to define the need. So, but because Michelle is actually pretty intimately aware with my personal case with my daughter, Jaden would have not fallen in that category, because we know that we absolutely must do all we can to prevent a 911 response. It's not that we didn't need it at the time. We didn't have appropriately trained 911 staff, so that would have potentially escalated the situation. So we didn't have the 911 calls. We didn't have police on scene if we didn't have the 911 calls, and therefore didn't have incarceration. Mobile crisis at that time, prior to Tennessee START, was not useful for that situation. It would be like, put her on the phone, and that wouldn't help. And we had tried many times to have psych hospital admissions, but she was precluded from admission everywhere for being too severe for treatment. So is there another way to collect the data of those that are falling, they're being missed in that? So is it possible to collect data on those that have attempted to be admitted into multiple institutions or facility cares that haven't been able to? How can we make sure that we're getting more accurate data?
Yeah, so the data that I presented, like I said, that's a very small sliver.
Yeah.
And that was what we utilized to justify bringing START and other programs to what we do. But I always like to point out that it is not all inclusive. That is the easiest data for us within DIDD to access, because we have oversight of those Medicaid Waiver Service programs. We have the integration initiative, which is something where we're basically merging all of our Medicaid waiver services into one waiver. That will give us access to anyone who's currently receiving services data. The access to the SIRS national database that we have with START gives us the ability to collect more accurate data with all of the individuals that we interact with in the state of Tennessee. Also allows us to compare, as Karen said, with the 13,000 other individuals across the country, how we compare state to state, what kind of services they're utilizing. So that gives us a much larger, and that's one of the bigger IDD data sources in the country, which was one of our big draws with like why we wanted START too. So there are other avenues and other research that's being done to try to get a better, bigger picture by a lot of resources outside of what we do. But certainly, and I definitely think it's needed. We're gaining more and more access to avenues to get a better big picture of that data as the state department.
And I'll just chime in that, hospitals probably don't all realize that they need this data, but as you guys are thinking about advocacy, hospitals are incredibly motivated to solve this issue, incredibly motivated. As hard as it is for you families to go to a hospital setting, it is equally challenging for a hospital not to know what to do and not to have the right services. That's literally why they created my program. So we have data on, but it's hard to pull. So the hospital, HANES, which is the Hospital Association of New York State, is actually putting together a survey for the whole state, all hospital systems, to understand why our population is coming to the hospital and where they end up going and why the delay is discharged. So the question in the chat about the rejections, we're tracking that now. So we're also willing and happy to connect Hades with any other state level hospital entities, because again, that's really where you're going to get kind of fiscal analysis and advocacy that I think is going to get new programs created. It just becomes a numbers thing, which I wasn't aware of before I started this role, honestly.
Yeah, and I can speak with Tennessee. I mean, we have the Tennessee Hospital Association, which we're collaborating with as well. So there's a good chance that there is an entity out there that has access to the hospitals across your state that can be helpful. We find it very helpful when working on partnerships to try to access as many of the providers at one time as we can. So meeting with the conference that includes the entire chief of police system for the state can be really helpful in trying to spread that message and get collaboration on a much larger scale.
The question in the chat of how to get someone's attention after they have tried to contact multiple state and county resources. And another one is just now talking about being ignored and the systemic invisibility of Black, Indigenous, and other families and individuals of color. And so I will just personally touch on my experience with how to overcome that. And maybe you guys have some additional options, but that was certainly a challenge for myself. But the way that I was able to kind of elevate my platform was through networking. So, you know, the squeaky wheel kind of theory, you just keep sending out emails, and we encourage you to develop your own Facebook page and start sharing your story. Use hashtags that other related type content is using so that you're matched to that. Join organizations like the National Council on Severe Autism. You can, I put our contact information up in the chat as well. You can reach out to us. Oftentimes NCSA will share stories from parents and get you some more exposure on those topics. You can join organizations in your state, like councils on developmental disabilities, that might be able to help plug you into meetings with your senators and your representatives so that you can start sharing those personal stories and what you need. But just getting involved with other parents. I know in Tennessee, Vance Goforth runs a support group on Facebook called A Voice for Joshua. He has a Facebook page, but then also a group, and then you can get with other parents, see what's been working with them and how they were able to get this service or get this policy changed. And it really, to me, is just about networking, because none of us have all the answers or all the connections that we need. And if we do it together, we're going to be able to get a lot more accomplished.
I wanted to note, Gabrielle, your comment about the health disparities. So we are doing some pretty significant deep dives into that. I do agree with you that we need to be thoughtful and checking our implicit bias and the systemic racism and the things that are happening. I don't have the data to talk about that at this point, but I promise you it is part of our DEI efforts, and it is at the top of our, kind of list of things that we need to be aware of and also looking to solve and rectify. So.
Yeah, and I can speak from the perspective as a State Department. It's really important to our department, to us, to be made aware of gaps that you all are seeing in the system. We try to be very responsive and receptive to those, and it impacts. I have a list on my computer all the time of the current gaps in the IDD and crisis system, and working on action steps on, okay, how do we start to move in a direction to resolve some of these issues? So it's really, I think sometimes, to Jackie's point, it's about getting to the right person and not stopping until you do, and utilizing every resource that you can to get to that place.
Absolutely.
And Daniel, I think what your sentiments are is likely what Jacqueline was saying, about we understand and empathize. We've got nothing for that level. I think we're working on, I know at least in our system, of quantifying and defining, well, here are the places and here's what you can do. Like Matt Siegel's papers on how actually acute psychiatric inpatient units can create programs for individuals with profound autism. I literally, dropped a stack of those articles on our chief of psychiatry's desk and was like, this is what we can do. There's a model, and a psychiatrist colleague of yours defined it. So connect with me, connect with the council. The more we share resources and message the same way, the more people won't be able to just say, we don't do that. Well, you got to do it. You got to.
Absolutely. All right, well, it's about time to wrap up. I am truly immensely grateful for the effort and the information you provided us today. We will be having this information up on the website within 48 hours, likely sooner. But give us some time to get that up. Just keep following back. And I put the contact information for everyone, NCSA, Karen, Michelle, Amanda, myself, all in the chat there. Anybody wants to screen grab that or copy paste it before we head off here. And if you have any questions, reach out.
Thanks, everyone. Thank you so much. And yeah, as Jackie said, we will try to get the recording of this up later today or tomorrow. And with any PDFs we can grab as well. So thank you to our wonderful speakers on presenting on such an important topic. Appreciate it. And to Jackie, our moderator
Thanks.
and organizer. Okay, everyone. So screen grab now because I'm going to sign off. Okay. Adios from California. Bye. Thank you.